Us today for our lunch and learn on brain health research. My name is Dr. Perry. I'm one of the faculty members who are co-leaders for the Healthier Black Elders Center. I'm also an associate professor at the Wayne State School of Social Work. I wanted to give a brief introduction of the Healthier Black Elders Center before we get started. So this center is funded by the National Institutes of Health, and it has been continuously funded for over 20 years. Many years ago, the National Institutes of Health put out a call for action to increase the participation of minorities in research and the amount of minority scientists conducting research on minority populations. This created various centers across the country that focus on a particular population. In Michigan, we created the Michigan Center for Urban African American Aging Research. We call it MICWAR. MICWAR is jointly run by Wayne State, Michigan State, and the University of Michigan. And the Healthier Black Elders Center is the community outreach core of MICWAR. HBEC, for many of you on the call, already participate in our programs, but it's a wonderful program that aims to address and reduce health disparities through research and education. We host various events that provide health-related education to the community with a focus on aging. We provide education on topics that range from diabetes and heart health to food safety, nutrition, healthy eating habits, and today, brain health. We typically hold these events in person, and we are hoping that you are able to enjoy our new virtual format until we get back in person again. So to learn more about our program, we have a website, www.mcuaar.org, or we have an office number, 313-664-2616. I'm going to say it again. We have a website, www.mcuaar.org, or our phone, 313-664-2616. Before we begin with our presentations today, I'd like to make a few announcements. Please remain muted during the event so we can hear the presentation as best as possible. Again, this webinar is being recorded and will be available to watch at a later time on our website. For those of you on the computer, if you have a question, you can submit your questions in the Zoom chat or in the Q&A box in Zoom also, and that is at the bottom of your Zoom window. If you are joining by telephone and you have a question that does not get answered by the end of our program, please call the HBEC office and leave a message with your question. One of our staff will follow up. So to start today's program, we're going to have a short presentation on a newer segment of our Lunch and Learn series called Critical Crossroads. Critical Crossroads was created by our advisory board members to engage in community conversations, advocacy, and strategies around issues of social justice. I myself sit on this committee, as well as Vanessa, who many of you know, and we've been working hard with our CAB members to put on these small programs. Many issues of inequity have been brought to the forefront this past year, such as issues of racism, discrimination, police misconduct, health disparities, and more. The advisory board hopes to present on various issues to maintain community dialogue, awareness, and provide resources for action. Today, we are lucky that today's Critical Crossroads will be presented by Linda Couch from Washington, D.C., who is a policy analyst at an organization in DC called Leading Age, and she is going to present on the eviction moratorium. And when we were thinking about the importance of understanding the eviction moratorium, I asked the CAB members who are on our advisory board, what if we got a national speaker to give us some information? So Linda kindly agreed, and so we are lucky to have her today. I am now going to turn it over to Linda, and just tell us what you know, and we are very excited that you joined us today.
Well, I am really excited to be here, Tam. Thank you, and really appreciate the work you all are doing in Detroit and across Michigan. So thank you very much. A word about Leading Age. We are a large national trade association. We have about 5,000 nonprofit organizations who are members of ours, and all of our member organizations provide some sort of service to older adults. So we have members across the aging services continuum. And one of the main things that our members do is provide affordable housing to older adults. And this is the part of our membership that I get to work with. Affordable housing is near and dear to my heart. I've worked in affordable housing policy for my entire career, and grew up moving a lot and understanding the value of stability in your housing, and really knew for, I think, for a long time that this was the world I would be working in. Our members include organizations like Presbyterian Villages of Michigan. I think that's an organization some of you are probably familiar with. PVM is an organization like other of our members that really put their heart and their resources into providing quality housing for older adults with low incomes. So that's the kind of work that we do. We really, my job is mostly focused on expanding the supply of affordable housing and making the affordable housing we do have better, making it as good as possible, and then making the programs as big as possible. Tam asked me to talk with you all today about the national eviction moratorium, and I'm happy to do so. People, I think, often, and partially rightly so, think that many senators and representatives live in a bubble, right? They're, rich people who live in a bubble who are untouched by the trauma or crises that are caused by something like an eviction. But I just wanted to share with you two quick things. One is that there are a couple of members of Congress who we know who've been personally touched by eviction. And one of them is probably one of the most powerful members in the House of Representatives, Congresswoman Rosa DeLauro from Connecticut. And she is the chair of the House Appropriations Committee. And that is an extremely powerful position in the House of Representatives. She oversees the full Appropriations Committee and all 12 of the House Appropriations subcommittees. And as a child, Congresswoman DeLauro was evicted from her apartment with the rest of her family, and speaks about that often. And I don't think it's any surprise to folks today that she is very invested in protecting people from eviction. And then another woman who is also powerful is Congresswoman Ayanna Pressley, and she's a representative from Massachusetts. And while she was not evicted as a child, she speaks really passionately about her mom being a tenant rights activist when Ayanna was growing up, and how they were often worried about retribution from their landlord and coming home or hearing a knock on the door while they were home, and having a landlord who was trying to push them out because of her mom's activism. I think that, that backdrop, just knowing that there are, and I'm sure there are others in Congress, but just knowing that there are people in Congress who have a sense of the trauma caused by an eviction, I think helps us understand, some of the decisions I'm going to talk about that Congress and the administration made about resources and the eviction moratorium itself. So way back when COVID initially struck, I think it was clear to policymakers that people who didn't have adequate housing, right? So they were doubled up, or they were tripled up, or quadrupled up, as people with low incomes often are, right? Because you don't have the housing choices to live exactly where you want to live. So doubling up and tripling up is very, very common. As is unfortunately living in a shelter environment where you are extremely close to other people. So not wanting to add fuel to that fire, Congress early on in COVID, this is last March of 2020, went as far as the government really thought it could at that moment. And in March in 2020, Congress passed a big COVID relief bill called the CARES Act. And it had all kinds of resources in there, all kinds of programs and all kinds of funding. But one thing it also did is it included an eviction moratorium for anyone who lived in federally assisted housing or in a building that was insured by the Federal Housing Administration. So that meant if you were a tenant in public housing or Section 8 or a HUD subsidized senior building, or you were in a low-income housing tax credit building, that your landlord was prohibited from evicting you for non-payment of rent. And that was a big deal that happened, and we were pleased that happened. But as the economy continued to tank and COVID got worse, the Federal Centers for Disease Control took a really historic step in the name of public health and issued an eviction moratorium for non-payment of rent for all renters in the United States. And they announced that eviction moratorium on September 1st of last year. And in its notice to establish that eviction moratorium, the CDC argued that the coronavirus presented a historic threat to public health. And here we see the federal government stepping in a way we've all been yelling about for decades, about the connection between adequate housing and health. And so this housing and health connection was really shown a bright light on it when the CDC issued its first national eviction moratorium last September. And they really thought, okay, we get this eviction moratorium in, there won't be any displacement, at least of existing renters, and that's going to help prevent the spread of COVID. As I said, the moratorium applies to all renters, but those renters had to do a couple of things, right? They had to sign a declaration and give it to their landlords to say, okay, you know what, we declare, I self-declare, I'm saying just for myself, I promise you, that I meet the requirements of being able to declare to participate in this eviction moratorium. You can't evict me because I can't pay my rent, right? My income is less than $99,000 a year. I can't pay my rent because I've had a loss of income, or I've had extraordinary expenses during this time, like medical expenses. I'm worried that I'm going to become homeless, or that I'm going to have to be doubled up or tripled up if I lose my housing. And that if I can, I'll make partial payments toward this. And so this declaration was just a piece of paper that tenants were supposed to be able to give landlords to say, hey, I heard there's this eviction moratorium, I need to participate, and this is why. And landlords had to comply. As you may have heard, many landlords fought the eviction moratorium in court, and some were successful in some minor ways, but the national moratorium on evictions for non-payment of rent continues to be in place. And that first one that I mentioned that was put in place last September was initially set to expire the end of December of last year, and it has been reinstated and extended, and now is set to expire in a couple of weeks on July 30th. But let me back up a little bit again and just note that in December, again, focused on how closely housing stability is tied to this public health emergency. In December, Congress passed another large COVID relief bill. And in that bill, they included $25 billion. That's almost half the entire HUD budget for 1 year. Congress provided $25 billion and for states and counties and cities for a new emergency rental assistance program, and really told states, okay, here's a whole bucket of money. We need you to get this money to landlords and the tenants they serve, so that when the moratorium on evictions ends, people are going to be able to pay that back rent that they owe you, because the eviction moratoriums just sort of delayed you paying your landlord. It didn't stop the debt you owed your landlord from continuing to grow. And so any rent that wasn't paid under the eviction moratorium was still accumulating and would be due when the eviction moratorium is over. But this $25 billion was provided by Congress to get that money to tenants so that any past rent that was due under the eviction moratorium or future rent for some time would also be paid for by this money provided by Congress. So, and in the meanwhile, the eviction moratorium was extended again and again. And then in March, another $21 billion was provided to this. So all told, $46 billion has been provided by Congress for what's called an emergency rental assistance program. And most of these programs, however, have really struggled to get off the ground. Of course, from the money that was provided in December, one would have hoped that because of the emergency situation and the deadlines for the eviction moratorium ending, the states and cities and counties would be able to get these programs up and running. But the programs have been very, very slow to get up and running, and that has resulted in the extension of the eviction moratorium deadline. And again, as I said, now the eviction moratorium deadline is the end of July in just a few weeks. Most of these programs they all have to provide rent assistance. Most of them provide utility assistance. All of them go back and can pay for rent arrearages. They can pay for penalties and late fees that the landlord is assessing because you missed your rent. But they look on a state and local basis, they all differ a little bit in their particulars. So you have to look and see how yours is metering out. The Biden administration, when the Biden administration came in January, it loosened some of the National Emergency Rental Assistance Program requirements to acknowledge that the previous program set up by the previous administration was like a little too complex and had too many unnecessary barriers for people to actually get the assistance that they needed to help pay their rent. We know too that Michigan has received more than $661 million for its emergency rental assistance program from this large chunk of federal money. And Michigan is, has its applications are open. Michigan calls the program a COVID emergency rental assistance program, or COVID ERA. And the program does cover rent and utilities. I also wanted to mention that for, so the National Eviction Moratorium, there are two things. One is that it's an eviction moratorium for non-payment of rent. You can still get evicted for a whole list of other things, right? For criminal activity, for all the other lease violations that are in your lease that aren't around paying rent. So for damaging things, for health and safety violations, whatever's in the lease that it's a lease violation, all those things are still could make someone eligible for eviction. But the eviction moratorium is only for you can't be evicted because you can't pay your rent. And you have to sign that declaration to declare that you can't sign your rent. The other thing I'll mention is that so it's only for non-payment of rent. And the other thing I wanted to mention is like who the eviction moratorium covers. It covers anyone with a lease or with a verbal lease, with a written lease. It covers if you rent in a mobile home park. It covers any kind of apartment rental, and it also covers HUD-assisted housing. And if you're in a low-income housing tax credit housing, or if you have USDA rural housing. But I will say, if you're in HUD-assisted housing, so you're in public housing or Section 8 or Section 202 programs, there is virtually no reason for eviction over non-payment of rent, regardless of the moratorium, because you as tenants or people as tenants should be able to get your income recertified, right? If your income goes down, you can ask your HUD-assisted landlord to recertify your income, and then your rent will go down to an affordable amount. But still, regardless of the fact that we don't expect a lot of HUD and rural housing tenants to apply for emergency rental assistance, it's possible and they certainly are eligible to do so. If you're a tenant in a tax credit housing, and it's hard to know like what kind of housing you're in if you're living in quote unquote affordable housing, but if you do happen to know that your building is primarily subsidized through the low income housing tax credit program, your landlord is not required to adjust your income when it goes down. And so we do expect many tenants of low income housing tax credit buildings to take advantage of the resources provided by the emergency rental assistance program. I'll also note that landlords are not required to inform renters of the CDC moratorium or of the emergency rental assistance program. And of course, like this has stoked a lot of fears that a lot of renters are not, have never been aware of the eviction moratorium or are aware of all these resources that the state of Michigan is really so eager to distribute now to protect people from eviction. And so hopefully you all can share with your peers and your colleagues that the state of Michigan does have this, more than $660 million in emergency rental and utility assistance. It's really, really eager to give out. Another interesting thing about all of this is that traditionally landlord-tenant law is not something that Congress gets itself involved with. And I find it so fascinating that that the CDC came in at this moment and declared the eviction moratorium at all. Because when you think of landlord-tenant law, you have to think about, what is your city doing on landlord-tenant law? What does your state say about landlord-tenant law? And it is very rare that the federal government gets involved in dictating anything about anything related to landlord-tenant law. But they certainly did here. So this was really a historic move by the CDC in the name of public health. And then the last thing I'll mention is that there's a lot of unknown about what's going to happen once the eviction moratorium ends on July 31st. We are not expecting another extension past July 31st. States now finally do have their programs fully up and running, but we also know that there are millions and millions of households, including 12% of renters age 55 and over, who are not caught up on their rent payments. And there is a real disparity among renters who are Black or Latino versus those who are white. Who are Black and Latino renters are much more likely to be behind on their rent payments than white renters are. And they're also the same households who are much more likely to lose their jobs during COVID. So there are so there's a lot that everyone is extremely worried, even though all this money is hanging out there to help people retain their housing. The lack of awareness about those resources, the lack of understanding how to access those resources, maybe processing times for once you apply for those resources, how long does it take for your landlord to actually get that back rent owed them? There is, I would say, a tremendous fear across the affordable housing world about what's going to happen after July 31st when a lot of landlords, and I would say particularly for-profit landlords without any HUD assistance, are really eager to start processing eviction paperwork. So anything we can all do to help educate people about these emergency rental assistance dollars would be really terrific. And with that, Tam, I'll pass it back to you.
Linda, thank you so much. That was excellent. It was detailed, but also so easy to follow, which is, really taking a big topic of housing and housing insecurity, really, and sort of helping us and the people on our call to understand it a little better. I appreciate it so much. Also, the critical crossroads was really intended to also look at what we call social determinants of health, meaning what are things in the social world or social problems, and housing is certainly one of them. So thank you, Linda. I encourage you to listen to, I would encourage everyone on the call to investigate more on housing and see if you have family members or friends that sort of some of these resources apply to in the city of Detroit, et cetera. All right, I am going to introduce our next speaker. Okay, hold on. Okay, speakers. All right, our main presentation today we have two speakers, Dr. Ellenbogen and Dolly Niles. Dr. Ellenbogen is a neurologist in Farmington, Michigan. He received his master's in public health from the U of M and his medical degree from Michigan State University College of Osteopathic Medicine. He has been in practice for over 20 years and specializes in headache medicine, memory and cognitive disorders, movement disorders, and vascular neurology. Dolly Niles is the executive director of Quest Research Institute, located in Farmington Hills. It is an institute dedicated to support both the researchers conducting clinical studies and community members who participate in the studies. And at the Healthier Black Elder Center, we've been getting to know Dolly in a few ways, so we're excited that we can hear from her today also. We'd like to give Dr. Ellenbogen and Dolly a warm welcome and a big thanks for sharing important information with us today on participating in research studies specifically on brain health. So I'm going to turn it over to them, and thank you so much for joining us today.
Hi, Tam. Thanks so much for having us. We're really excited about sharing a little bit of what we do here at Quest. And Dr. Ellenbogen, who so graciously has offered to really give a really nice overview about memory health, what's going on in memory research, importance for minority populations to understand, and might be a few things special for that group, and hoping to get to know your HBEC community better, going forward. So I'm gonna share my screen, and let's see if I can figure out how to do that. Okay. And I would say, Dr. Ellenbogen, if you would like to, let's see here. I have a slide here I wanted to just share, just to kick off a little bit on the importance of memory health and what we're seeing, trends we're seeing right now in the United States. Alzheimer's disease is the most common cause of dementia, and it accounts for about 60 to 80% of cases. So there are other kinds of dementia, but Alzheimer's is a specific pathology. It's a certain way that the brain is, being impacted. So they estimate right now about 5 million Americans are living with Alzheimer's, and it is the 6th leading cause of death in the United States, which is really quite astounding. And we're expecting, of course, that to grow as our boomer population tends to be the largest group in, of our citizens. FDA approval of a new medication. So I'm going to turn it over to Dr. Ellenbogen so he can give you a little bit more on the background and progression of how Alzheimer's can, and how we can maybe do better with our own memory.
Okay, well, thank you very much for having me. It's a real privilege to be able to present this information, and I look forward to also answering questions as we move on. So, as Dolly had mentioned, Alzheimer's disease is actually the most common form of dementia that we see, but there are other forms of dementia. And the way to think of this is that the dementia is a big umbrella, and there are lots of things that come under that umbrella. And many of the things that you see listed here are actually characteristic of not only Alzheimer's disease, but also of dementias in general. And we expect to see with dementia progressive memory loss. And with conditions like Alzheimer's and other forms of dementia, this is often very, very insidious when it begins, and people don't really recognize that there's something going on. And the person who's experiencing these symptoms may not recognize it either. It can often be attributed to normal aging and so on. But as things progress, we see this cognitive decline, and it can be as simple as having memory issues, but it can also be that people are having problems finding words, they'll repeat themselves. They can start to have things like anxiety and depression become an issue with this. And this often isn't recognized as a problem until it starts to impact activities of daily living. Family members will often start to take over activities for a loved one. So it may be paying bills or preparing meals. It may be that providing transportation can be an issue, handling medications and so on. And it's often very hard to understand when this needs to occur, because we want to maintain our loved ones' independence, but by the same token, we also want to try to keep them as safe as possible. What often happens is that it begins with this stage called mild cognitive impairment. And this is where others may recognize that there's a little bit of a problem and things aren't quite right. But by the same token, people are able to really function day in and day out with the activities of daily living, and it doesn't interfere with their function. The minute that it interferes with their function, then it becomes much, much more of an issue. There are some risk factors that are identified here, and I think that this is really important for a couple of reasons. Number one, these are conditions that often impact communities of color more than they do the population as a whole. There are certainly pockets where diabetes or hypertension, high cholesterol, smoking, and of course, family history. And family history is one of these things that is very difficult sometimes to tease out. We certainly know that, there may be a family history of, well, grandma had memory problems when she was older, but is that really significant? We know for sure that family history is important in people who have young onset dementia. So people who develop memory issues in their 40s and 50s, and even to their early 60s, that is probably much more important than people who are what we would classify as late onset dementia or over the age of 65. But as you see here, there are a lot of lifestyle type issues that really can be a contributing factor to the development of Alzheimer's disease. And so this gives us an opportunity without medication to really try to prevent Alzheimer's disease by making dietary and lifestyle changes, which can address blood sugar, address obviously smoking, address cholesterol. And this can be done many times through diet and exercise, which is very hard to achieve. And we all understand that, but can be addressed and help avoid, in some cases, these issues. Next slide, please. So one of the things, and you may have heard a little bit about this, especially in light of the new drug that was approved for the treatment of Alzheimer's disease. And it's a controversial drug, and I'll get into that in a couple of minutes. But what happens in Alzheimer's disease, and this is very specific to Alzheimer's, so this is not what happens with all dementias, but remember, Alzheimer's makes up somewhere between 60 and 80% of people's dementias, and so it's the most common one. We start to have this accumulation of this abnormal protein, which is A beta 42, and you can see that listed here as plaques. And what happens is this protein naturally exists, and then for some reason, it starts to aggregate and accumulate, and then starts to fold into what are called beta-pleated sheets. And it's when this abnormal form of the protein actually starts to accumulate that we start to see changes that would be consistent with the development of Alzheimer's pathology. So again, this is all looking at a microscope and looking at brains under a microscope. And so we don't do that obviously in people who are living. And so we are still working on trying to find biomarkers or other ways of formally diagnosing Alzheimer's with the highest specificity as possible, without actually needing to look at someone's brain under a microscope. As these plaques start to form and this clumping and aggregation of this protein occurs, we start to see the brain react. And this can react in a number of ways. It can react in what we call neurofibrillary tangles. We also can see inflammation. And as a result of this accumulation of this abnormal protein, which is toxic, and the formation of tangles and the inflammation associated with it, that leads to loss of nerve cells, and these nerve cells start to die off. And this can sometimes be captured when imaging is done. So if someone were to have a CAT scan or an MRI of their brain, we can see shrinkage of the brain that occurs. The problem with that is that we also see shrinkage of the brain just normally as we age. And so it can be very, very difficult sometimes to determine on a scan what is normal aging and what is not. And again, we are developing biomarkers that can be helpful. There are certain imaging techniques, and they've started to measure the loss of tissue in certain areas, one being an area called the hippocampus, that may serve in the future to help us make a diagnosis, and especially as we have new and better treatments, may also help us to tease out who is suffering from Alzheimer's, so that we can specifically use treatments that target not just dementias in general, but the Alzheimer's pathology in particular. Next slide, please. So currently, there are a number of drugs that are FDA approved for the treatment of Alzheimer's disease. And with the exception of the newest one called Aduhelm or aducanumab, they are really all targeting symptoms of Alzheimer's disease. And three of them are very, very similar to one another. They're marketed under the names of Aricept, Exelon, and Razidine. So those are the brand names. They're all old enough that the generic formulation of those medications exists. And their intention really is to just try to help promote or improve memory a little bit. The effects really are modest, and it's unfortunate. I mean, you can see that those drugs have been around long enough that they're now available as generic medications. And so there hasn't been a lot of advancement. There's one other medication that is approved that works in a little different fashion, and again can be helpful. It's approved really only as an add-on to those other medications. It's a medication called Namenda, although people will sometimes prescribe it off-label for a variety of reasons to use it by itself. They have a limited effect, and quite honestly, they're really modest in their effect, and many patients will ultimately stop the medications due to a lack of effect. Or because of side effects. One of the things that I tell my own patients to set expectations is that only about 20% of people actually see a noticeable improvement in their memory or their symptoms when they're started on these medications. For about 60%, it may actually hold them steady for a while, but ultimately they do continue to decline, as we expect with any one of these progressive neurodegenerative disorders. And then in more advanced Alzheimer's, there may be a role for some people in terms of helping behaviors. That leaves one other medication, this medication Aduhelm or aducanumab, that was recently approved. And as I had mentioned, its approval was quite controversial, as a matter of fact. And the reason is that it went through really quite a limited process for approval, in the sense that it did not meet its primary endpoints in the studies that led to the approval, but an analysis of the data afterward did show that it made a difference in terms of some aspects. There's a rating that's used in many of these studies called a CDR, and in a subset of people who had completed the study, there was an improvement in the CDR versus those who did not receive the medication. So the thought is that this drug may help slow down the progression of Alzheimer's, but the controversy is really threefold. Number one, many people are concerned because of the path by which it got approved, because it didn't necessarily go through the standard path of approval, and as a result, there's still a lot of unanswered questions that need to be studied. Number two, there are external panels, and I think many of you may be familiar with this idea of external panels now because of the development of vaccines to prevent COVID-19 infections, where external panels would review data and make recommendations. And these are experts in the field who can look at the effects, and they have a real sense of the context of what a drug means and the importance of the drug. And first and foremost, the question is it safe? And second is, does it work? And really most studies, those are the questions that are really being sought to find an answer to. And the panels actually did not recommend approval. And so that was another issue that led to the controversy. The third issue is that this new medication has some challenges in terms of safety. And the safety, about 40% of people experienced either what are a small areas of hemorrhage in their brain or bleeding in the brain. And again, very small, so it often did not cause symptoms, and it's not an unexpected effect of these medications. And others experienced a little bit of local brain swelling. And it's thought that that's actually a marker of the medication breaking up some of those plaques that are the target of this drug. And so some people would argue that's a sign that the drug works. But about 40% of people experience those kinds of issues. And so there are still questions about the safety and the long-term effects of the drug. And so this is the controversy. And this is why research is done, is to answer these questions of, does the medication work and is it safe for people to use? So among the neurology community and among those of us who really see a lot of individuals with Alzheimer's and neurodegenerative disorders, it's not clear how this medication is going to be used and when it would be used. And we all agree that there's more research that has to be done to answer these questions. But the good news is not only will there be more research with that medication, there are a number of other medications taking a variety of different approaches toward treating Alzheimer's disease. And so not only do you have power by making adjustments in lifestyle, and we'll talk about diet in a minute, but also there is an opportunity to see further development on the pharmacologic side using medications to treat as well. Next slide, please. So I started to get into this a little bit, but I wanted to just highlight some research facts. So every medication that's approved in the US, it requires clinical trials to be done with participants in the United States. So it's not, if a drug is approved in China or in Europe, it's not accepted as medical fact that that will work in this population. And so that sometimes leads to a situation where there's a drug approved in one country, but it's not available in the US. There's a drug that we use to treat a condition called Huntington's disease that for the first 15 years or so of or slightly less of my career, we would have patients get the medication either from England or Canada because it wasn't available in the US. Ultimately, US studies were done and it was approved and so on. And it takes a long time. This is a process that typically will take anywhere from 8 to 15 clinical trials. There are several phases. The first ones are really geared just toward establishing, is this safe? And they'll use people who are healthy volunteers, so not necessarily with the condition. Then they start testing it in people with the condition, again, looking at safety and also trying to find what the right balance between the safety and effectiveness is. And so that can require many trials. And over time, there are thousands of participants who actually participate in this development process. And the latest statistic that I've seen is that it takes over $1 billion of investment to develop a single drug to the point that it gets FDA approval and is brought to market. So one of the reasons that people, we all complain about the cost of medications. I complain about it both as a consumer and the fact that sometimes the cost limits the access of my patients to medications I want them to take. But that's why drugs are sometimes so expensive. And so if it's for a relatively uncommon condition, you have a much smaller market to capture. And so the cost of the drug may be higher. Whereas for conditions that are much more common, oftentimes they can make up that development cost because it's spread out over a much larger population. But a clinical trial in and of itself is a very clearly defined protocol. And so it's like a recipe. And so you have to, in the beginning, identify the right person to participate in that study. So if it's an Alzheimer's disease study or someone with mild cognitive impairment that's felt to be a precursor to Alzheimer's disease, they have to meet certain criteria for that. There's testing that is established. There's also safety that's captured right at the beginning. So if someone has a pre-existing condition or an issue is identified on laboratory studies or on an EKG, for example, that may preclude someone from participating in a study. And that's fine because we want to make sure that we keep everyone safe. And again, these are experiments. So we want to know that we can do everything in our power to maximize safety while also seeking to answer the question of, does this medication work? What happens is that in the very early phases, when safety is really the primary focus of the studies, it can be very restrictive in terms of who gets in simply because of safety issues. However, as the process continues and the drug goes through later stage studies, they tend to be more permissive in terms of allowing people in who may have other coexisting issues. And the reason that they do this is because they want to really, first of all, open it up to a larger population. And more importantly, they want it to reflect the community at large. And so as close to a real world scenario as possible. And one of the things that becomes really important in this is the inclusion of people of color in those studies, because we want these studies to actually reflect the population of our country as a whole. The other thing, and this is something that sometimes should really give people pause rather, is that participating in clinical trials is typically free for the person who participates. Sometimes they'll actually be reimbursed for their time and of course for travel and things like that. So there may be a small stipend that's offered for people to participate, but understand this is not, the goal is not to incentivize someone to participate. It's simply to reflect the time that the participant and sometimes a caregiver spend in the participation. This is not something that requires insurance. And quite honestly, sometimes people will participate in studies because it allows them to see a doctor and to perhaps be treated without insurance. And there are a variety of reasons why people may want to do that. That can include things like not wanting their insurance to know that they may be dealing with a particular condition. It may allow for testing that they didn't want their insurance to be aware of, or in some cases, it's simply because they don't have insurance at all. And as a researcher and as a research site, we want to make sure that we allow anyone in who is interested in participating in a study, and of course, making sure that their safety is maximized. Next slide, please. So I wanted to just share a couple of the studies that we're doing. And there's some other things that are going on that are quite interesting that I can allude to, but because of confidentiality agreements, I can't necessarily talk about in any great detail. So the first study I wanted to discuss was this green memory study. And this is a investigational medication that is actually intended to rebalance bacteria in the gut. And the reason that this is really interesting is this is a very novel approach. The good news is, as I had mentioned, this is something that actually is already approved in other countries. So it has been shown, it has met the standards of both safety and effectiveness in those countries to be approved for use, so that it can just be prescribed by a healthcare provider without being part of a study. But as I had mentioned, in the US, in order for a drug to be approved in our country, studies have to be performed in our country as well. One of the things that's really interesting, and I think you're going to hear a lot about in healthcare in general over the next decades, because we're really in our infancy in terms of understanding this, is there is a brain-gut connection. And what I mean by that is we know that bacteria that exist naturally in our gut and help us to break down food and other aspects of our health can send signals to the brain, and that some of those signals can actually tell us that we're hungry, and it can lead to food cravings and can lead to unhealthy patterns of eating as well. And so there's work on this in terms of obesity and cholesterol and the impacts on hypertension. And it's being studied in migraines and even Parkinson's disease and so on. And this is a medication that's intended to rebalance that relationship and help treat Alzheimer's in that way. And so, although it's been approved in China, as well as several other countries, they're now testing it on a worldwide scope with the hope that they can have approval and ultimately offer this treatment to others worldwide, so that we have new tools and a new approach to treating Alzheimer's disease. Next slide, please. The other thing that is going on, and again, this is just a sample of the kinds of work that we're doing. One of the issues that medications used to treat brain disorders have in general is, how do we get them into the central nervous system? There is basically a barrier in our central nervous system called the blood-brain barrier that blocks things from reaching the brain. And that's a good thing. This helps keep infections and other chemicals from getting to our brain because they can't cross this blood-brain barrier. However, it also creates problems when we're trying to treat brain disorders, because we want to be able to allow treatments to get into the brain. And there's been a lot of work over the last at least 2+ decades that I can think of in how to tackle this problem. And there have been some very, very innovative ways. And one of them is this brain shuttle approach. And this same approach is being developed for a number of different disorders. So it's not necessarily only in Alzheimer's disease, but other neurodegenerative disorders as well. But essentially, a medication is fused with a brain shuttle, which is a platform that we know will pass through the blood-brain barrier. There's been lots of work done to show that that platform can transport medications through the blood-brain barrier so that they can then actively do their job within the central nervous system. And so this is another study that we're involved in. What I'm hopeful about really in the world of Alzheimer's research is that we have treatments like this that are ultimately, it can be used in a number of ways. One of them is to take treatments to try to help improve memory, but also the brain shuttle itself may be ultimately helpful in bringing treatments in that could slow down or stop the progression. None of this will reverse the damage that's already done. But again, we're trying to at least slow down or stop the progression so that we can halt the disease in its tracks and at least keep people stable with regard to whatever symptoms they may have. And there are other approaches being taken, and there are some approaches that are looking at the inflammatory aspect of this disease. As I had mentioned, when we start to get this abnormal protein collecting and aggregating, it creates inflammation. The brain doesn't like the fact that this abnormal protein is there. And just like if you were to sprain an ankle and you get swelling, that's inflammation. The brain will have some inflammation as well. And so by blocking inflammation and the damage that does, may also be helpful at the same time that we're treating the underlying pathology. So those proteins that are aggregating. And so in the end, it may be a multi-layered approach in terms of how we actually attack this disease. Next slide, please. So this is just an example of some of the things that happen in a study and what it's like to participate as a study participant or a volunteer in a study. And remember that participation is always voluntary, and people who participate in studies have the right to withdraw from the study for any time, at any time, for any reason. Although certainly we try to encourage people who've made that commitment to stay in the study as long as there's no issue with their safety. But people will drop out for a variety of reasons, and that's well within their rights. And we recognize that and remind people of that on a regular basis. And that's really part of this first step, which is informed consent. Then we go through the process of reviewing medical history, medications. There are questionnaires that are completed. For Alzheimer's studies, there's cognitive testing that is performed, because in the end, that's often the primary endpoint of these studies, looking at cognitive testing before and after. And in a study where we're potentially looking at, does a treatment slow down the progression of the condition, we will see that the cognitive testing in the people who receive the active treatment may be stable or decline at a slower rate than people who did not get an active treatment. So those are important sorts of things. People will have physical examinations and neurological examinations. As I'd mentioned, an electrocardiogram or EKG are performed, looking at vital signs, height and weight. There are blood draws for safety. both to make sure that there's not confounding factors, but also to make sure that the medication doesn't impact, for example, the liver or the kidneys in an adverse way. And then for a study like the Green Valley study, there's something like gut microbiome collection. And it sounds interesting, but sometimes it's as simple as taking a stool sample. So nothing that is necessarily invasive. Oftentimes imaging is utilized, so an MRI of the brain or a CAT scan. And then of course, medication dispensation. And for people that are in a study where they're getting medication, there's also a process of reviewing afterwards to make sure that people were actually taking it in the appropriate way. And there's some checks on compliance, so pills are counted to make sure that people are really using the medication in the way that they're supposed to be. Next slide, please. So in the end, we always wonder who should participate in these studies. And as I had mentioned, we want this to be as broad a swath of people as possible so that it reflects the community with which we live in. And so, most of these studies, because of the nature of Alzheimer's disease, do have a lower age cutoff of 50. And many of the studies will have an upper age limit. Sometimes it's 80, 85. Some studies may be even a little bit higher. For these particular studies, it's mostly 50 to 85. People, of course, have to be experiencing memory issues or have a diagnosis of Alzheimer's disease. And because of the nature of memory type studies and studies for Alzheimer's disease, it's important to have a study partner as well, someone who can come with the study visits, but also will sometimes fill out questionnaires about how they think the individual is doing, and not just the questionnaires that we utilize to assess the individual. And this is important because one of the challenges with Alzheimer's, as I had mentioned in the beginning, is that the person who is living with the disease often doesn't recognize the problems they're having. And so this is a way of getting a more complete picture in terms of understanding what problems may exist for an individual. And then again, so it's not as simple as I just want to sign up and participate. There is a little bit more to it, but again, it can be really rewarding for people who participate. And it's very often we hear that people have learned a lot from participation, and they have learned a lot about their condition. They have learned a lot about themselves. And the other thing that they really benefit from is the support they get from the staff at a research site. So it can be study coordinators, the research nurses, the physician who's overseeing things, and so on. And so you have a lot of people who are your advocates and going to bat for both your safety. And we all hope that we're finding something that's a new and better treatment. Next slide, please. So I already tackled some of this, but again, why become a volunteer? People receive individualized attention for both you and your study partner by people who really have an expertise and an interest in brain disorders. Again, some people, it's really the opportunity, given the shortcomings of what's currently available, to gain access to something that they might not otherwise be able to access. And then there are many people who are really just very, very generous, and they say, I'm afflicted with this condition and I want to make a difference for people, whether it's my family members or the community at large. And it's very possible for one person as a volunteer to cast a very long shadow and impact thousands of people down the road, especially if the study that they participate in leads to a new and better treatment for Alzheimer's disease. And so for any one of these reasons or all of them, these are why some people really choose to become a volunteer for a particular study. Next slide, please. And as I had mentioned, for minorities, the participation is really extremely important and highly valued. And we understand there's a history, especially for people of African American descent, and good reason to mistrust the system. People have been unknowingly or unwillingly placed in experiments, and that is entirely unacceptable. And as I had mentioned to before, people who volunteer to participate in a study, this is something that their consent is provided. They have the ability to withdraw for any time and any reason. But by the same token, Alzheimer's disease disproportionately impacts people of color. And that's because some of those coexisting conditions that I mentioned before, diabetes, high cholesterol, hypertension, can actually, they do exist at higher rates within minority communities. And so there's an opportunity to really make sure that these populations are represented within the studies. And the other reasons why it's important for minority participants to enroll in studies is that although we are all people and we think of ourselves as being the same under our skin, there are some differences because of where people's ethnic heritage is from. There are some conditions, for example, that exist in people of Middle Eastern descent, that are blood conditions that are really extremely rare in other populations. Similarly, we see this, of course, in people of African descent, where there are some differences that were protective in many cases from wherever that person may originally have their history and their ancestors, but may not necessarily provide that same protection here in the US. And so we want to make sure that medications react appropriately and work in similar ways for everyone, because we want to make sure that we can, in the long run, if a treatment becomes available, we can identify who would best benefit from these treatments. And also, there may be differences in dosing because of genetics or metabolism, or in some cases, it's external factors like diet and environment. And so at Quest Research, one of the things that's going on is to just make sure that there's a community awareness about clinical trials and make sure that there's access to everyone who lives in the Metro Detroit area, because we want to have people of color participate because it's a reflection of our community and our country. And it's really important that these studies do reflect the population as a whole and not just a small swath of population. Next slide, please. So just to summarize, there's a lot going on in our understanding of Alzheimer's disease. One thing that isn't here in the slides, but I think is important, I had mentioned there are some things you can do, and obviously controlling risk factors is important. The only thing, people will often ask about things like diet and so on. The only diet that has really been shown to be beneficial at this point, but I think it's important to understand, is that a Mediterranean style diet has been shown to be effective in addressing the potential risk factors. But even when memory problems start to pop up, it can impact the course of the disease. And it's not clear whether, excuse me, this is because of particular nutrients, or it may be the change in the gut microbiome, those bacteria that are living in our gut that we know have an impact on diseases like Alzheimer's. But having a diet that's heavy in fruits and vegetables, using legumes, things like chickpeas, and much more sparingly using refined carbohydrates, so white breads, and then of course, even more sparingly with meats and especially red meats. And that has so far been the only thing that's really proven to have a significant impact. But it's hard to make those lifestyle changes. Just like I had mentioned with exercise, it can be very, very difficult, but exercise can also help. And so those are things that you can do today and can mitigate some risk, and therefore can hopefully avoid this truly epidemic issue of Alzheimer's. As our population ages, we are going to continue to see growth and really an explosion in Alzheimer's disease. So I was going to stop there and just open it up to questions that people may have.
Well, first of all, thank you so much for this information. It's really, really critical that all of us sort of think about our own health and things we can do. And I appreciate your tips, as well as sort of understanding that to benefit everyone, participation in research is one way to contribute. So I will look out to see if there are any questions. Also, feel free to put them in the chat, anyone on the line, or you can just also call our office if that makes you more comfortable, and we can follow up with the speakers later. So one couple questions for Dolly or Aaron. One thing is, if people want to participate in a study like yours, how do they go about that? That's one question. And then two, when the study is done, completed, how do we find out what happened in the study? So, what kind of follow-up occurs? And then I have another question in the chat, which is, please elaborate more on things we can do. So maybe just even repeating some of the things in your list of things we can do. So those are three things. Thanks.
I'm going to start, and I'll leave the first question for last, and I'll let Dolly answer that. But so the things that people can do to make sure, or to really try to put themselves in the best position for avoiding Alzheimer's, are really, much of that is basic general health things, and it's good public health, and looking at the obesity epidemic that we have in our country, the lack of exercise, poor dietary decisions, and you had mentioned it actually, Tam, before. The social determinants of health are really, really important, and we understand that there are, within certain communities, a real scarcity of healthy food options, for example, and so it can be very, very challenging in some communities to be able to access those things that make up a healthy diet. But avoiding or limiting red meat and emphasizing whole foods, especially, so whole grains, fruits and vegetables that are as close to their natural state as possible. And it can be simple, like avoiding fried foods. And the other thing I think that is a sneaky one that people get sucked into are beverages that contain sugar or artificial sweeteners. The more we learn about artificial sweeteners, for example, and how that drives diet, but the other part of it that is really important is that those artificial sweeteners have an impact on the microbiome in our GI tract, in our gut. And one of the things they found is people who will eat or drink a beverage that has an artificial sweetener then crave sweets afterwards, is because the signal is being sent from those bacteria in our GI tract. They taste something, we taste something sweet, and it should create a certain fullness for that appetite, where in contrast, it actually drives that desire for more sweets. And so it's things like that we don't think about, and we're really just learning more about, but that's where that part comes in. And so using those whole foods, the natural foods, exercise, as I had mentioned, and it's really the general guidelines for exercise. So exercising in a moderate way, ideally 150 minutes a week, which translates to 30 minutes five times a week. And it can be a balance, though, of both cardiovascular exercise, so a nice moderate to brisk walk. It doesn't have to be anything more than that, but also using some resistance training to work our muscles and our joints and so on is very, very important. So those are things. And then, of course, risk factor modification. So maintaining a healthy weight will help avoid some of those issues like high cholesterol and diabetes, hypertension, and so on. And so it's good general health will often reduce the risk factors for Alzheimer's disease.
And just one question. What about smoking?
Well, I mean, smoking, again, drives a lot of those other conditions. And we know that smoking is bad for the brain on a number of levels. It causes vasoconstriction of blood vessels, so it causes the blood vessels to narrow. It causes inflammation, which leads to changes in the brain as well, and obviously the impacts on the lungs and the heart and the blood vessels elsewhere in the body. But as a neurologist, of course, the brain is my special area, so we worry about that. Everything else, from a neurologist perspective, everything else is there to serve the brain.
Interesting.
But the heart doctor would probably say the same thing about the heart. So,
oh, super.
But smoking for sure is an issue as well.
Okay, and then I'll let Dolly chime in with the sort of what are if people are interested, how would they get involved, and then what happens when the study is done? How would you find out
Okay.
what happened?
Well, I think there's two things. So on the study that's done, because I'll share my screen and it'll have contact information to call Quest. But when the study is done, the FDA has tried to be more stringent with sponsors on sharing study data. And the problem with that is, so we are seeing more and more the outcome of here's 12 patients that you had in a study. Here's the people that had drugs. Here's the people that didn't. Typically, we will find out after the end of their data analysis if the drug is going to proceed. So since one of those studies that Dr. Ellenbogen shared about is phase 1, that probably won't actually come to market for 6 to 8 years. However, we'll probably know after the first year of this trial, will it proceed to the next phase? So I would say participants can call and say, that study that I was in, is that still going on? And we will probably know whether it's going to continue or not. We are usually told when it is disbanded.
One thing to jump in, I'm sorry, I just want to, because one of the questions that a lot of people will have when they participate in a study is, did I get the treatment or did I not?
Mm-hmm.
That's one that is hard sometimes to be able to answer that question, because they won't necessarily divulge that information at all, unless there's a safety reason, which we would need to know that for.
Mm-hmm.
But the other thing is that sometimes they'll share that information more than 2 years after someone's participation in the study has ended. So
right.
It's one can't go into the study expecting that they're going to know that answer. And it's really a toss up as to whether they will find out. But usually if they find out, unless there's a safety issue, it's something that occurs fairly far down the road. Sorry, I just wanted to make sure that was
true.
right.
I think
That's all true.
important. And then the other thing, I guess, at the Healthier Black Elder Center, we really try to think of ways to not let researchers go missing, in the sense of, if you volunteer for a study, any one of the members of the PRP, our participant resource pool, you're entitled to ask a lot of questions before you participate. You really need to understand what voluntary consent, you're voluntarily consenting and participating. And then, we think, making sure we have venues for researchers to share what they've done. So we do that in our newsletters, or we do it at community talks, actually even like lunch and learns. We usually bring researchers back and have them say, I did a study 2 years ago. This is what we found out. And this kind of helps us stay connected for the whole full circle of research too. So so I would just say that what I like in your talk today, both of you, is that you're very understanding of what experiences the participant goes through, like from their point of view, what would they want to know? And again, that's sort of, it shows your experience in doing research, for sure. But let's see, Dolly, do you want to share your contact information with that?
I do.
You can,
Here we go.
Okay. Go ahead.
So here's the phone number. You can just call Quest, 248-957-8940. And actually we have an 800 number. It is 888-QUEST-24, which is usually easier to remember. We do advertise on WJR pretty regularly because we offer free memory screens and have for several years. We are a National Alzheimer's Association site and offer free memory screens for folks, as well as do quite a bit of research in many other areas. Dr. Ellenbogen is actually a movement disorder specialist, so he's an avid researcher in Parkinson's and essential tremor. And you can also go to the website, which is questri.com. And there's a way you can sign up. And if you sign up to join the Quest, we do communicate with our folks. Sounds like HBEC does also. And if there's an approval, so folks that were in the old aducanumab trials heard when the approval went out, which is really exciting, right? It's exciting to hear that they're part of that. And I would add too, even if people are in a trial that isn't necessarily successful, I would submit to you that in every trial they learn. We learn something more about the disease, better way to, treatments. We really do. So it's not in vain, to participate. Absolutely not.
Right. And in fact, some people would say when a drug isn't going to go to market is when you want to know, well, okay, let's not
Let's not
send this
spend
one
time
out.
there.
That's actually, to me, the safest thing that a study would find out, which ones that really should not be
Yes.
taken further.
Yes,
Um,
and I would want to add too, Dr. Ellenbogen touched on he's absolutely right on the exercise and the diet. Those are definitely things people could be doing now to help their memory. The only last I would mention would be possibly, to consider having memory health screenings. We offer them. It's more and more getting to be, I think, advised for folks. We do it for the rest of our body. I think memory health screening is important to do as well, just to even to do with your own physician so that they can track along with you, so that they can be with you if something were to arise.
And I would say, as a social worker in me, sort of understanding who you can count on as you age is also really important. So figuring out who your friends are and your family members and who would be good in emergencies. But even sort of, we know that a lot of older adults with larger social networks, they really, they get a lot of support and rides to doctors, but and sort of in touch with more information, when people pass it on to them, et cetera. So I think also
Yeah.
don't underestimate social networks too.
No, and that being said, I think our number one barrier to people participating in a research study for memory loss is a study partner. We have many patients that feel like, I know there's something going on. I don't really have someone that I can ask. I don't want to be a burden. I don't, so that is very important because it is really, as Dr. Ellenbogen advised, it is required, and I think they may be surprised in the network how many people might be willing to help you. So I think it's to be open-minded about that, so that you can get care that you feel like you need.
One question that's just come up in the chat is, are memory exercises that are online effective? Are there
So,
good websites out there, or?
so interestingly, there's a lot of attention, and I'm going to cover two things with this answer, because one that hasn't come up yet, but often does, at least in my own clinical practice, are those sorts of brain games and things like that, and how effective they are. And the answer is, we really don't know. The studies that have been done so far haven't necessarily demonstrated a benefit, but there's a lot of people who would argue use it or lose it. And so, staying mentally active, I think is actually really important. And for people that are passive and are consuming information, by sitting and watching TV and not engaging in things, I think that really can be detrimental. So it's not that those activities in and of themselves have proven to be beneficial. But it's also perhaps that when you study it, you need the right control group, which is the people that are doing nothing rather than the people who are doing some other form of activity. The other thing that I just wanted to address briefly, because I feel almost as if they're a little bit predatory, is you'll hear or see advertising for a lot of different supplements for brain health. And the thing that people need to remember and understand about supplements is that they are regulated not like medication, but like vitamins. And so it's a very different standard. And actually, a number of years ago, the advertising went away entirely. And the reason it did is the FDA sent a cease and desist letter to, I think, like 40 different manufacturers about the claims they were making. And gradually we've seen these ads start to creep back in without the data to really back up the claims that are being made. And so, some of these supplements are extremely expensive. And when patients I'm seeing in my office, or when people just in general ask me, are they worth it? My answer is usually, there's not a reason to think that they're going to harm you in any way, but they don't have the evidence to support that it's really effective. And so I think that that's an important thing to keep in mind. And so, it's one of these challenges, because people say I don't want to take medication. I'd rather do something natural. But first of all, natural things are medications too. And many of them haven't gone through that same rigorous process of testing for both effectiveness and safety that an actual medication that's FDA approved has. And so it's a hard balance to strike. The
Right.
natural way to do things is, again, the diet and exercise and those kinds of things.
Yeah.
Well, I think it's been a great program today. I think we've both learned about housing policy and what the federal government wanted to sort of put in place, which is very crucial for many people. And then we've also learned about sort of very interesting ways to approach brain health and also what's happening in brain health research. So I want to just tell everyone that today's presentation has been recorded. We would like to thank Linda Couch and Dr. Ellenbogen and Dolly Niles for such wonderful presentations. Also, we will be loading this recording up to the website. If there's anyone that joined us today that is not a member of the Healthier Black Elders program and would like you to join, we can talk to you more about it and perhaps sign you up over the telephone. If you can call us at 313-664-2616. And then when you get to become a Healthier Black Elders Center member, you get our newsletter, you learn about research studies, and learn about future programs like this one today. I also want to let everyone know that next month on the 12th, same August 12th, which is now a Thursday, we're going to talk about the COVID vaccine. And we've got a panel of experts on the COVID vaccine and what to think about it and sort of the road ahead in COVID for more health information on that particular topic. So I would just say, thank you so much. Can you address the gut brain? I guess, Dr. Ellenbogen, I don't know if there's more information about the gut brain. Sorry, I missed it in the chat. Is there more to say, or could they contact either one of you for
They
more
can
information?
call. They can
Yeah,
call.
and you can talk about it, but
We can.
yeah, okay, great.
The one thing I would say about
yeah.
that is that research and our understanding is really in its infancy. So we know it's important. And I think there's a growing body of evidence every day of how important it is, but we aren't sure what to do with the information yet in many cases. And so that's really going to be something that's a cutting edge area of medicine, at least for the next decade, if not longer.
Also, I just again wish everyone a healthy summer, especially as the world is opening up. Stay safe, enjoy your time with family and friends. Thank you so much for this health information, and we will see everyone in August, on August 12th, for more information about COVID.
Thank
Take
you.
care, everyone.
Thank you.
Bye.
Bye.